they want. Meanwhile, let us there is a problem because probably you need to add me as a co-host because it is not allowing me to share the screen.
So it is done, sir.
Okay.
Kindly switch on. Okay.
Yes, now it's coming. Fine. So this is what we'll do today. And first we will have a recap, any question and comment, and then we have done exercise yesterday. So I will discuss that exercise. If anybody has tried, we'll see that. And then we have the one topic, actually, the Markov models. And this is the last topic. And here again, my focus will be on that to understand the basics so that you read any paper, any document. There are so many papers nowadays, so you'll be able to understand that what's going on here. And then if we have time, we'll have an open session, and then I will like to listen to people that if they have any idea about any study or anything that, that we can do. But before that, let's start with recap. Any question? Okay, so there is no question. So about the exercise now, is there anything? Anybody has tried that exercise?
Sir, the answer is 15.16188 per quali, sir.
Okay, who is that? I cannot see them.
Sir, Pranav.
Pranav, it is 15.16. Anybody else has tried, but was not successful, that kind of thing? That's also okay.
Yes, sir. I tried to solve the problem taking the cost data and the query, but I had difficulty in incorporating the data on the life expectancy and the total number of children, n is equal to 1,000. How will we incorporate this data in this analysis?
Okay. Okay. Good. All right. Understand. Anybody else want to say that, any problem? Okay. So if not, then let me see that if I can, help here. And what Pranav has said, I think his answer is correct. And so since nobody will see that what he has done, so what I'll do, I will show that how is to be done. And so just to quickly walk you through the exercise that how this type of thing should be done. Now in real life, actually, when you have software, you don't have to do only manually like that. But you should now be able to understand what the software is doing and how to interpret the data. So, and how to feed the data, actually, what kind of data I need to feed. So that's why it is important at least once in a life to do it manually and then leave it to the software. So the answer is first. So this was the exercise actually, that first you have to populate the decision tree. That is, what are the probabilities, what are the cost, what are the, qualities, etc. And you have ultimately you have to find out the incremental cost effectiveness ratio. So what we did actually, this is the scenario you will see. That is the way we populated. Now, if you have that exercise with, if the thing is there, you remember that there are n 1,000, total number of people 1,000, So SNCU or no SNCU, that was the decision problem. And in SNCU, some people will be alive, some people will be dead. Those who are alive, they will have three outcomes, either of these three outcomes: no disability, minor disability, and major disability. And or they will be dead. If the dead story is finished, in the no SNCU case, similarly, there are two chances. Two things might happen, either of two, alive or dead. And if alive, then no disability, minor disability, major disability. So we have to really find the probabilities, and later on the cost and quality, everything on there. So first, let's do the probabilities first. Now, if you look at SNCU, probability was 0.7. Now, here the 1000 thing will come into picture. So 0.7 multiplied by 1000. So N, number of alive children is 700, right? Because total is 1000. Probability and probability of in SNCU is 0.7. So there are 700 if all of them go to SNCU. Similarly, if probability of alive is 0.7, naturally probability of dead is 0.3, so N equal to 300. By the same argument, probability of alive in no SNCU case will be N equal to 400, and dead is 0.6, so 600. So that's why 1000 things will coming. We're using this data, 1000. Now, about the right hand side, you will see that from no disability, minor disabilities, we have the probabilities, but from that similar way we calculated N. And then cost and Q. How do we calculate cost? First, how do we calculate N? Very simple then. 0.28, 28% of the 78 is 197, 196. 700. Out of 700, 28% will be no disability, 43% will be minor, and major disability will be 29%. That is the data given. So accordingly, just multiply with that N, and then you get the new N in each box. 196, 301, 203. Now that's cost and quality. There are some cost data given. And if you remember that cost data are like this, that if develops no disability, a newborn is sick, SNCU, what will be the cost? 818 rupees per head, per person. Similarly, minor, 1024. And if it is a major, then 1200. And similarly, if they don't go to SNCU, then what is the cost of no disability, minor, and major? So this is the hypothetical data. From that, you can first, step 2, calculate the expected cost of no intervention plus. That is the bottom, this part, no intervention. So what is the expected cost? Individually for each box you can calculate. You know that expected cost is basically, as you see that P equal to 20, but N equal to 100. So 100 people didn't have any disability. Those who have not gone, no SNCU case, 100 people, 400 people are alive, and then 100 people out of them, no disability. So per child cost is 1000 rupees that is given. So expected cost will be 1000 multiplied by 100 equal to 1 lakh. Similarly, for the minor, cost is 1100 and N equal to 100. So 1,10,000. E cost for major 1400 per unit and N equal to 200. So you got 2,80,000. Add all of them, then you get the total E cost of no SNCU. So you got 4,90,000. By the same argument, actually, you can calculate it the e-cost of intervention, that is the upper part of the story. Here C equal to 800, 118, N equal to 196. Simple, multiply them, then give total. Similarly, minor, only major, and you add them, you get 7121152. So per unit cost multiplied by N is the simple answer. This is, you got the cost of SNCU, and earlier slide you have got cost of no SNCU. Now you calculate the QALY. How do you calculate the QALY, and how, now the question was, how do you life expectancy, how do you use that? Remember that this is no intervention, so go to the bottom. If you remember that the QALY of no disability is equal to 1, that was given. So if a child newborn is not disabled, alive and not disabled, and expectancy is 64 years. So therefore, 1 multiplied by 64, that is 64 quality adjusted life years will be generated. So since the full value is given 1 means perfect health. So 64 years perfect health. So QALY will be 1 multiplied by 64. And then there are 100 children are there. So 64 multiplied by 6400. Similarly, minor you can easily do now. QALY was given for 1 child for minor thing is 0.7. Yes, Pranav is asking QALY equal to length of life multiplied by utility value. The utility value is 0.7 and the length of life is 60. So 0.7 multiplied by 60, and then there are 100 people, so 4,200. And similarly, you get the last one. 0.4 is the utility, and your length of life is 55, and then N is 200, multiply all of them, 4,400, and then add all three, you get the QALY, expected QALY for no SNCU is 15,000, add 3. By the same argument, you get value of intervention, which is, that is the upper part of the graph, no disability, no minor disability, no disability. And here the QALY is 29652, adding all three. So now we have got all the required data. So we can now form this table. So no SNCU cost was 4,90,000, effect was 15,000, and SNCU, we got the incremental cost. How do you get that? The difference between these two. And then you have got the effect. So incremental effect is 14,652. So divide incremental cost by incremental effect, and you get this 15.16. How does it how do you interpret that? That it will take about rupees 15 rupees to generate a QALY through SNCU. And it's so low number, so this can easily go as a very strong argument in favor of SNCU. That is the answer. Any question now? Anything that you couldn't understand or clarification?
Good evening, sir.
Good evening.
Hello.
Yes, go ahead. Who is that?
Sir, this is Shoma.
Shoma, yes.
Yes, sir. Sir, actually, I'm having problem with the step 6, that is the cost effectiveness analysis part. Will you please repeat, sir, again?
Sure.
Okay, sir.
So the first question was populate the decision tree. Populate means
Yeah, that was okay. That is okay.
And the second was estimate. So first, what we do, populate it.
Yeah, that is okay.
It's
That I
okay.
have understood.
Then
That
we
is
have
there.
the ICR. Now ICR, what is ICR? Incremental cost
Cost
effective ratio.
effectiveness ratio.
So you get two data, cost data and effect data. See, in the cost data, again, you get two types of cost data. One is without intervention, another
And
is
with
with
intervention.
intervention. Similarly for the effect. So we need 4 steps actually now. First, without intervention cost. So what is without intervention? That means no SNCU.
No essential.
So go to the bottom. And then you see there are alive and dead. Those who didn't go to SNCU, some of them alive, some of them dead. How many alive? 400. How many dead? 600, according to the probability. So we want to know what is the cost of now the whole no SNCU case. Now this whole alive case. So what is the cost of alive? There are 3 options. If you are alive, then no disability, minor disability, major disability. In the case of no disability, the data was given
N equal to
that
100.
N equal to 100 we calculated. How did you calculate that alive
The
N equal
probability.
to 400, then 25% probability, that means 100. Now C equal to 1000, that data is given. If you go back, you'll see that this is
That
the
was given, right.
unit cost. That is the given. So you have unit cost 1000, and then you have people 100. So per person cost is 1000. You have 100 people. So if you now go to the top
1
left,
lakh.
1 lakh.
It is 1 lakh. Right.
By the same argument, what will be now minor? How do you explain? You do it. You tell me.
Minor with the cost given is 1100. That is
1100
unit cost.
per child.
Unit cost. Unit cost
Unit
is
cost, yes,
1100 and the number N is 100. So it
100
will be 1100
multiply.
multiplied by 100. So it will be
Good.
1,10,000.
Excellent. So
Yeah.
major
And
is
equally
similarly.
the major. Yes, sir.
So then once you get that, all 3 options, now you add them. What you add them is then get your total cost for no SNCU actually. Because if you are dead, there is no cost. So so alive only is the situation here. And so these 3 possible expected value will be a kind of
4,90,000.
4,90,000. By the same way, now step 3 will be with intervention. Same argument. But you have to go now top. Alive is 700 people. And they also have 3 options. And per unit cost is 818 given. N equal to 196. How did you get that? Because 700 is the N.
700 probability is 0.28 by that we calculate.
28%. So you get 196. So you multiply 196 with 818 and you get 160328. By the same argument, you get 301 multiplied by 1024 and finally 203 multiplied by 1200. And then here the cost is 712152. This is the cost part completed. Now the effect part. QALY. Again, no intervention and intervention. So no intervention, go to bottom. And for QALY, you need to have the utility value. If you remember that, the utility value is given like this, that if a child has no disability, utility value is equal to 1. That means if the child lives 1 year, he or she will live 1 perfect healthy year. So it is 1. Whereas with minor disability, we have assumed utility equal to 0.7. That is, she will live, but only 70%. And then if it is a major disability, then it will be 40%. So if that is so, the first one is that those who are no disability, their utility value is 1. And how long they will live? 64 years. So per year 1, 64 years, therefore 64 multiplied by 1. This is 64 again for 1 person. 1 person will generate 64 perfect healthy years. And how many people are there? 100. So multiply this. 64 multiplied by 100. What about minor? Now, one person in 1 year generates 0.7 year. If is minor disabled, as if you are living 1 year, but since you have minor disability, actually you are living 70% of your life in a sense. So living 1 year with disability equal to 70% without disability. So that's why it is called utility value 0.7. So 0.7 per year, how long the child will live, and according to the data, will live 60 years. Life expectancy is 60 years. So multiply that. It will be 42 and n equal to 100. 42 multiplied by 100. So by the same argument, you get the equality of measure. Is it clear? Hello?
Yes, sir.
I think Dr. Shuma Chakraborty is around, and is she around? Because she asked a question actually. She was trying to explain to her. She might be disconnected or something happened. Shoma, are you there? I think we
Yes, sir, I am in the line, sir.
Oh,
Can you hear
so-
me?
Yeah, I can hear you, but can
Yes,
you, did you hear me that how the
Yes, sir,
quality?
yes, sir.
Okay.
Yes, sir.
So good. So no intervention, then you have to got the numbers, you add them, it will become 15,000.
Hmm.
Now you can do the last step with intervention. Now tell me, how do you do that?
With intervention.
With
Okay.
intervention,
With
No.
intervention, alive is that is a utility value. For with intervention, the Kali is 1. Life
utility value
expectancy
is 1. Yes, I mean, utility value is 1.
utility value is 1, and the life expectancy is 64.
64,
And we have n is
196.
we have n equal to 196. So 196 into 64 into 1.
Yes, so this is 12544. By the same argument, then the second box will
Second
be
box n equal to 301. So we have to multiply this 60 into 0.7 into 301.
301. So this is 12642, and the finally
measure.
get measure.
Exactly.
So you got the this part also. So now here, put in the value here. No SNSU 49, 4,90,000. This is you have
This is
got
cost.
from your step 2.
Hmm.
SNCU S1 to 152, you have got it from step 3.
Yes,
So
sir.
the difference between these two will be incremental cost, which is 22142.
Difference
And
between the two cost. Okay. 2
yes,
to 1.
that will be the incremental cost.
Okay, sir. Achha.
Similarly, effect, no SNSU 15,000. This is the step 4, I think you have got. And the last slide, you have got Quali 29652 with
This
intervention.
difference is the incremental effect.
This
That is
difference is incremental 4652.
2 minus no SNC.
Yes. 29652 minus 15,000.
15,000 is 14655.
So 52. So now divide incremental cost by incremental effect. You cannot divide that, and you got the number 15.16. I see. This is the ICER.
This is I see. Yes. Okay,
Yes,
sir.
the incremental cost divided by incremental effect, which is 15.16. What does it mean? That it will take an INR 15.6 rupees to generate 1 quali through SNCU. So this will be your economic argument there, and then you can say that, look, through the SNCU in my hospital, I will generate 500 qualis or 1,000 qualis, and that means multiply 15.16. Then you ask the government or anybody to organize that, can you give me this money? And they'll be very happy because this cost per quali is so low that it's very good scenario.
Okay, sir.
Okay.
Thank you, sir. Yeah,
Okay.
it's clear now. Thank you, sir.
All right. All right. So this is what our exercises. So we will, if there is no other question in this, we'll go now to next, well, today's topic, which is basically Markov model. And the reading I have given this, sorry, I forgot to give you the name of the book actually. I think the same book I have referred in the yesterday's class also, so you can check with that, otherwise I'll give again. And this is a very good book actually, chapter 9. It not only gives you the concept, but also give you a step-by-step process, how do you do this through Excel and Triage. We shall discuss the Triage is one software, you can Triage Pro. And you can also do it Excel, you have to add some program there, and then you can do it through Excel. So it explains step by step how do you do that. In today's document package also, I have included some very few papers, just as sample, that how people do that. And second, one Word file where I believe that there is again step-by-step guidance to how to use it in Excel, do it in Excel. Unfortunately, the software, in my case, is corrupted, so I cannot use this software, so I cannot show it in my computer now. So introduction is the Markov models. If you have heard of that, this has been actually named after Russian mathematician Andrei Markov. And it is being used not recently by health professionals, but extensively used by physics, engineering people, physics people, and many other areas it is used. Now, health or medical decisions are also being used extensively. What it does actually, it is suited for the decision where the event's timing is important, and when events may happen more than once, reflecting transitions from one state to another. I will explain that, but it's basically modeling long-term outcomes, where costs and effects are spread over a long period of time. For example, if you think about COVID-19, it's just goes on and on and on, and then you actually face difference in situations in your health. You start with a very good without COVID situation, and then get infection, and then you have some problem, and then again a sub problem. And the unfortunate people actually by this through this progress towards death or very major severe disability. So this is the situation where Markov models can be used. Decision tree actually is a kind of a snapshot kind of thing, but Markov models can capture the dynamics very well. In other words, when the disease progresses over time, actually it is used in disease management, whereas decision tree can be used for health system, other areas. For example, the last one we have seen, SNCU versus no SNCU. This is not a disease, it's actually a health system intervention. But Markov usually, it is implemented in disease management, where patients grouped into a finite number of states. They are in good state, they're in worse state, that kind of thing. I will show that. And time progress in equal increments. There is every 3 months the status changes, or every 6 months changes. And this progression from one state to another state called transitions, and there is a probability on that. For example, what is the probability of that the person who is very low symptoms, almost asymptomatic, what is the probability that that person will develop breathing problem and will have serious problem? You must have some probability. If not, you can do a kind of experiment. You can do a trial and see that this happens. But those who are working, they have some idea now. Similarly, there is a probability of improvement. And so that probability is important. We need that probability. And whenever you, in a particular state, you are progressing, and this is called, time lag is called cycle. And every cycle or every state, we call it certain cost and defined outcome. Now I will explain this thing now with a bit structured way. We will see that how to do a Markov analysis. And these are the steps. We don't have to read all these things now. We'll go step by step. So anyway, we will cover that. First thing in any Markov analysis is that you have to define the states and how the one state is allowed to have transition to another state. So you have to identify the Markov states. Now, how do you identify? It can be clinical states. For example, you can divide in a broad way that it's well, it's disabled and dead, that kind of thing. Or you may call it in COVID-19 case asymptomatic, and then you can call it another state is basically that having problem but not hospitalized, and then another state is that you need oxygen kind of thing, and then ultimately ICU and then death. So these are the stages, these are the states one can have. So it looks like this. But it's a very simple. That suppose there are three states we are considering. First state is well, that you have no problem. Second state is ill, that is you have problem. And third state is dead. Now the relation between these three states are very interactive. For example, well to ill, there is an arrow. That means that if you are fine, then you may become ill. Similarly, if you are ill, then you may become well. And if you are well, you may remain well. So that arrow comes back to it itself. If you are well, then you may be dead. Everything is perfect. Or next day the person is dead. That may happen. And ill, you may be dead. And actually, there should be another one, which is ill remains ill. That is also possible. It's not drawn here, but that is possible. What is not possible that no arrow should come out of dead. That is, there should not be any reverse movement from dead to either ill or well. Because when you are dead, all these things are no possible movement. So these are called health states. Now look at this, health states must be mutually exclusive. You cannot be in two states simultaneously. You cannot be well and ill at the same time from a particular disease. So you have to either or situation. And it should cover all the people. Suppose we are looking at 1,000 people at a particular point of time who have come to you or whom you have seen, they must fit in either of these categories. Must fit into a health state at any point of time. And individuals can only be in one state at a time. And the period of time is no particular time, and period of time is known as a cycle. And at the end of each cycle, the patient can stay in the same health state or move to another health state. For example, suppose the cycle is 1 year. So at the end of 1 year, the well people may remain well, or a certain percentage of well people may become sick, ill, and a certain percentage of well and ill may be dead. So it is dynamic. That is today what you see in 2021, 11th November, if you look at 1,000 people, 13, today is what? 13th November. So if you now get 1,000 people, you have some, and all of them are okay, well, then in 2022, 14th November, after just 1 year, this 1,000 may not be in the same category, same state. Some of them may be ill, some of them may be dead. Usually that is the situation, or maybe all of them will remain well. That is also possible, but there are other possibilities as well. A more complicated story is like this, where not just three kind of thing, there may be many states, A, B, C, D, E. These are level of disability. A is very good, B is slightly worse, and then E is the extreme, maybe death, something like that. And cycle, or it may be year, which may be month, which may be week. So you can divide COVID-19 progression in like a 5 steps, 5 states. And then you can look at 4 weeks. So usually, it happens within months or within a month or within 2 months, etc. So conveniently you can divide the cycle. So this will be the situation actually. The whole population in the first year or first week or first month, they will be in the first row. Some of them maybe A, some of B. So we don't count the dead people. So usually in the theory, all of them will be in A, in a good health. And then in the next year, this will change. Third year it will change, or third week it will change, fourth week it will change. That is the markup process actually. And that makes it very interesting. And then it may happen this way. If you look at the arrows, for example, in the first year, this is the situation. And in the second year, what happens? From A, there is an arrow to D directly. That is the person who was now like perfectly fine today, tomorrow that person may reach suddenly at the D level, gasping for breath. It may happen, or maybe C level, or maybe B level, or may remain A level. Similarly, in B, from B in the second year or second week, some people will be recovered and go back to A level. Some people will remain at B. Some people will go to C. And then again from C, some people will be better. Those who are under ventilation, for example, C probably is under ventilation, they will be out of ventilation and go back to B, but still not perfectly cured. So, or maybe C may remain same, or maybe C to directly from ventilation, you may still end up in your grave. So you die. So it may happen. So there are different types of probabilities. You see that all these things are uncertain. All these things are chances. All these things you have to express in terms of probability. So you need lots of probabilities now. That what is the probability of A in first year going to D? What percentage of, what is the probability that a perfectly fine person will develop severe breathing problem next week? That kind of thing. So that's why you have to now define these probabilities. That's called transition probabilities. These are the key elements of Markov people. And it predicts how people will move from one health state to another. And it will be like this, that P11, the probability of remaining well, P12 is well to disabled. What probability is, what percentage of people will be disabled? And P22 is who will remain disabled, that kind of thing. P33 is basically that the dead people actually, how many people will dead. This doesn't mean anything actually, because dead will always remain dead. So this is not necessary. So this will always remain one. So in terms of these probabilities can be fit in a matrix actually. Like there are three situations. For example, you are fine, suddenly you have a stroke, and then another situation is dead. So P12 is that how many people who are well, they will have stroke, 7%. P13 is that how many people who are fine will die, 0.01. So if you add them and then 1 minus this will be P11, how many people will, or if you know what percentage of people will remain well in the first year, then you can directly write that. So at the end, actually, there will be no probability because all of are dead, and no probability of stroke, all of are dead now. So P33 equal to 1. So dead to dead is 1. The dead will always remain dead. The stroke people may become well becomes stroke. Stroke may become dead, but dead will not become stroke or well. So that is the idea. And here one particular assumption is taken that it is always progresses forwardly. It's a very simplistic assumption actually, that from well you got stroke, and from stroke you got death. But the reverse from stroke to well is not given there. That is put 0 here. So this is very simplistic assumption, but now people can model this return that is from unwell to well. That probability you can also use. And from that, what we call got Markov trace. I will come back to that. I am not doing that. This from probability, you can now find the numbers actually. If you start with 100 people, in t equals 0, your cohort is 100. So 100 are well, no disease, no dead. Now next year, what happens? Suppose 70 people are well. That means what happens to the other 30? 20 of them is disease and 10 of them are dead. So 70 plus 20 plus 100 is 100. Second year, T2, 51, 26, 23, always the addition should be equal to 100. Only the share of well disease dead will change. Gradually, as you move along the cycles, the number of well people will be less and less, number of dead people will be more and more. So if I take a cycle of say 50 years and take a cohort of 100 people, at the 50th year, probably I will not find anybody well or disease. Everybody will be dead anyway at that time. Here, some particular assumptions are taken, which are called Markovian assumption, simplistic assumption. And nowadays, some of the assumptions you can deal with those assumptions, but originally these were the Markov assumptions that that all people are homogeneous, regardless of past health states. That is, it is not really distinguishing between distinguishing between the one person to another person on the basis of their past history. Somebody has a diabetes, somebody doesn't have, then accordingly they will have different states. No. When we are taking probabilities, we are assuming that all are homogeneous. So what happened prior to that cycle, when we consider t equal to 2, what happened to t equal to 1, that is not usually considered in this model. That is the assumption. That's why Markovian model is also called memoryless model or memorylessness of Markovian model, that every cycle is independent of another cycle. That may not be the reality every time, but then nowadays the modeling you can change this assumption and have the software is now allowed to keep you some memories, and accordingly some probabilities you can put there. But basically this happens. This doesn't change the results very significantly. This assumption is okay. I mean, based on this assumption, lots of studies are being done. No problem, not much damage will be done. Step 4, you have to decide on a cycle length, that what is the cycle length? How frequently I have to consider that one person will shift to another state. For example, if a person is well today, usually how long it will take that person to reach the second stage of a particular disease. So that will be your cycle length. And definitely it will vary from disease to disease. In some cases, it may be annual. For example, the cancer cases, usually annual cycle is taken. But in some COVID case, naturally 1 year will be too much. It changes so frequently that it has to be much. Leprosy case, for example, I'll take annual there. But on the other hand, if it is a asthma, for example, or any chronic disease, most of them are come under annual cycle. When should I stop? You have to iterate cycle 1, cycle 2, cycle 3, cycle 4, and then gradually the oil people, the cohort is changing from oil to they are moving towards disease or death, etc. When should we stop? If the model has an absorbing state means death. If the model has death as one state, then one option is that you can run until all of the cohort end up in the state. For example, you take, say, 100 cohort, as I said, and 50 years you take that cycle. So after 50 years, anyway, nobody of this cohort will leave. And that doesn't mean that you have to study for 50 years. These are all now simulation based. That is, you put in the computer and give the inputs, and computer will produce the cycles. And then, so how long the computer will keep on this iteration? That is a question here. How many cycles it will do? It will do it in seconds, but how long, how many cycles it will consider? Or alternatively, you may consider that way that I don't want my all cohort to reach that death stage. And before that, I want to stop and see, because many of them will die from other causes. I don't want to consider that. So many people will then force the model to stop after a specified number of cycles. And now the important thing is come. You have got the states. Now you know the people, how many people are in what state. And then you have to find out what is the cost, unit cost of staying in a particular state. For example, if staying at ICU is a state, then what is the per unit cost of staying at ICU? Similarly, if home isolation is a state, symptomatic home isolation is at stage, what is the cost per unit home isolation? That kind of story. So that from one state to another state, what is the cost you are bearing? Similarly for utilities. Utility values will also change from one state to another. Naturally, utility value means how good you are feeling. So definitely utility value of home isolation is much higher than utility value of staying at ICU. So different state will have different utilities. So how many utilities generated every state? So that kind of thing, and what is the things are accumulating. Now, it will be seen in two scenarios. One is without intervention, another is with intervention. With intervention, what is the cost of each state? How many people are in each state? What is the cost and what are the utilities there? And with intervention, same. And then take the difference, just like incremental, and then do incremental cost effectiveness ratio. So this kind of cost and utility value you may attach. For example, if you have three Markov state, one is well and on treatment is doing well, home isolation, say is $150 a pound, and utility is 1, suppose. You are not in home isolation, you have problem, you are hospitalized, you are disabled in the same sense, and at that case, or you will be in ICU, whatever, 10,000, utility value drastically reduced, 0.4, and in the death, your cost is 0, utility is 0. So, but this is a very simple. Actually, you have many states, and therefore you have many. Because I will show an example of the real life scenario. So, analyze and evaluate the model. Let me stop for a minute here for a while and see that if there is any question now at this point. Yes, no question? Or maybe you want to see till end?
So there is, so, hello?
Yes, go ahead.
So there is a question, are the compartments watertight? That is between the well and the disease. I mean, the table that was shown, that well, diseased and dead. Dead
Yes.
is the end stage, okay, but diseased persons can get well. It's not that the disease.
Yes. Yes, I mean,
So
they are independent, they are mutually exclusive. You cannot be well and disease at the same time. So
Yes,
they
sir.
are different, and initially simplest Markovian model do not allow to reverse back. Reverse progression is not possible. So well, you can become diseased, and disease you can become death. From well, you can die also. But definitely you cannot be well from death.
No, two states
Anyway.
can't exist
But
simultaneously.
you can go to disable to well, that is possible now. No, in the extended Markovian model now, it is possible to do that also. So you can go back. So your utility level will increase from 0.4 to 1. Your cost will reduce once you go back. So that is possible, yes.
Okay, sir. Thank you, sir.
So step 7 is analyze and evaluate the model. So the story is like this. So in cycle 0, everybody is well. In next cycle, some people disappeared. Where did they go? They go to recurrence. And recurrence means in this case disease. And some of them, so look at vertically now. Some of them, 2 of them died actually. Total of these people is equal to the cycle 0 cohort. So the same cohort, they are now distributing. In the third period, less people are well, more people are diseased, and there are more deaths now. Ultimately, if you go on and on and on like this, everybody will be in this box. Death. Now here makes the problem actually that if they die from other problems, then how do you? So that's why now researchers, what they do, they create 2 states. Death also has 2 states. One is death from that particular disease, and another is death from other reasons, other causes. So nowadays, you have to mention that so that you can see that from the well people, they can die from other problems. So they are going to dead 2. Some of the people, well, they are going to dead 1. 1 means the disease you are considering. So by this way, you can create 2. So it will be like this, a stroke prevention case. Well under treatment and disabled, stroke and dead. So initially 1,000 people, and there are dead 0, disabled 0, total 1,000. 92% will remain. We know that probably that 7% of them will have stroke. From any prevalence study, you can get this data. Out of 1,000, how many will have stroke? So 7% means 70 people, and also from the prevalence study, you get how many people die out of this. So 0.1, 10 people. So 70 people will be disabled and 10 people will die. So subtract this 80 from 100 and 1,000, you get 920. Next period, the probability remains the same. 92% of it, 920, 846. Now you see the numbers in disabling are increasing. Percentage remain the same, but increasing. And it is cumulating actually. That in the second cycle, when you are considering disabled, you are taking this 95. You are taking actually the earlier people who also died, and 75% of them, they are 25% will die, another assumption. So this is slightly complicated thing. You just have to look this the matrix, and then you try to understand what is going on here. And only thing, the left well part is basically you just constantly can multiply by the same probability and do that. Total will be always remain same because it's the same cohort, and dead numbers should increase, disabled numbers should increase, but after some time dead will surpass the disabled. and well will definitely decrease. So it will look like this kind of thing, a complicated thing. That I think this figure we have shown without numbers. So well, recurrence and death, well, disabled and dead, and cycle is 1, 2, 3, and it is 0.6%, 60% will remain well. So 10,000, 60%, 600. But out of this 10%, 10,000, some of them are directly dying. How many? 10%. Some of them directly dying due to the disease. Some of them in the next 30% about will be in the diseased, disabled state. Will not die directly, but will be in a disabled state in that state. So if you look at second month or second year, you will find that 3,000 people are suffering and 1,000 people died of the disease and 6,000 people well. Come to third year, you will see that 3,600 are well, more people are diseased, and dead number has increased. Both same. So the same cohort is moving, and every time it is accumulating. Especially in the disease group, you have to see that if they remain in the disease state, some of them will remain in the disabled state for every across the cycles. So you have to count them also. And finally, the calculate and the cost effectiveness analysis, you have to calculate the cost and quality. For cost, you now know how many people are in each state at each cycle, numbers. What you need now, the unit cost of each state, per patient cost of each state. And multiply the number, will give you the total cost for each cycle. Follow the same process for calculating quality. Now, since this is a long term, if it is annual, 5 years, 10 years kind of thing, then you have to discount the costs on quality. And we have learned how to discount that. So you have to apply the discount. Software will do that for you. You don't have to bother much. An example. There are 3 states, well, recurrence and death. Cohort of 1 lakh people. Annual cycle run for 55 years, 55 cycles. And about 20% of recurrence state requires palliative care before death. These are the data given. And some cost and utility data are given. For example, cost of 1 year in the well state. If you are fine, well, it may mean that you are under treatment. You are not really well in that sense. You are under treatment and keeping well. So the cost will be 350. But in the recurrent state, where you actually severe problem, and then you are probably in ICU somewhere, 3,190. And if you are before death in hospital or something, you have needed palliative care. 20% of the people are doing that, getting that 1,400. Similarly, if there is an intervention, we are assuming that 46 rupees or $46 or whatever. Utility value of remaining well state for 1 year, 0.89. Utility value remaining in the disease state is 0.5. And of course, utility value for death is 0. And then you get, this is called Markov trace. So you get first the without intervention story. First 3 cycles. So there are 55 cycles, as I said. So just giving a picture of 53 cycles. In the 0 cycle, 1 lakh people are well. Nobody recurrent, nobody dead, nothing, no cost, no quality, nothing. In the second year, 60,000 people well. 30,000 went to recurrence, 10,000 went to dead. Now you have to calculate the cost, cycle cost per patient. How do you calculate? It is given in at the bottom. Remember that 350 if you are well, 30,000, sorry, 3,190 if you are in the recurrent stage, and 20% requires palliative care. So that's an extra cost. 20% of the recurrence will require that. So your data will be 350. Look at the bottom, cycle cost 1, 350. How many people are well? 60,000. Plus recurrence is 30,000. What is the per unit value? 3,190. And then plus 20% of this 30,000 will require extra cost on palliative care, and per unit cost is 1,400. So total add these and then divide it by the total number of cohorts, population, 1 lakh, and you get 1,251. This 1,251 is placed here. Similarly for QALY 1, 0.684, how do you get this number? If you remember, the utility value of remaining well is 0.89. Utility value of remain in recurrence is 0.5. So 60,000 people well multiplied 0.89 plus 30,000 people are unwell. Their utility value 0.5, add them and divide by 1 lakh, you get 0.684. And then cumulative cost means that what is the value of the first cycle and second cycle, add them, and then you get this cumulative QALY and cumulative cost. Second cycle, cycle 2 is the same formula. You will get this. You can try this on your own. 1583.4. Cycle QALY will be 530. Cumulative cost will be 2834. Which is derived by the earlier cost 1,251, and then the second year cost. Add them, you get cumulative cost, cumulative QALY. This way it continues, and 55th round, all are dead. And cumulative cost is this. Cumulative QALY is 3.2. So this is for non-intervention. Do the same for intervention, and when you have the intervention, naturally the number will change. Well will be higher a bit, recurrence will be less. So all the numbers will slightly change. And then you do the intervention arm and then calculate ICR. That cumulative cost of intervention minus cumulative cost of no intervention divided by same cumulative difference between intervention and no intervention will be ICR. I'm giving a real life example. This was a study done, published in Lancet actually, and then later on, these two gentlemen actually used the data and simulated from that data and analyzed an intervention. This intervention is very interesting actually. When ICU, when you have ventilation, many people are under sedation. That is, you are ventilated and sedated. Now, some people think that that's a very bad strategy. What you need to do actually, and sedated people, it's very difficult to get them out of ventilation. So the intervention is that let them sedate, but then can we have every day morning and awake them, and then can we keep them awake and do something so that they remain awake for a while, and then whether that works, whether the ventilation, they can come out of ventilation early, and whether mortality is reduced. So they have intervention group where they did the intervention. This is main result from the Lancet study actually. The intervention group, they found the ventilation 3 days and control group ventilator 3 days. And all of them collected the data, and this is the result of the data. And they found that intervention group are doing well actually through this. Their mortality percentage is also reduced. Ventilator 3 days also reduced, whatever way you measure it. and who successfully extubated at 28 days, percentage is higher in the intervention group. They have come out of this ventilation. So you have the three states here: intubated with ventilator, extubated out of ventilator, and dead. So intubated, you remain one possibility is intubated, and then from intubation to extubation, and the reverse also. That is, you may get in to a ventilation and out of ventilation off and on, and may remain without, and then from both the state you can go to dead. So there are two-way journey between in and ex, but there is only one-way journey from intubation and extubation to death. So transition matrix, two metrics are there. One is intervention group and this is control group. Which gives you is actually probability. These are probabilities of intubation, extubation, and death. So the last corner in both cases is 1, which means the dead to dead is 1. And first row, first cell, I and I, that is those intubated, they remain intubated. How many people? 86%. This one, next one is E to I. So it is this percent. And the third one is dead to I0. So here you see that from I to E and E to I both possible. And I to dead, the third one actually 0.018. So these are the things for the intervention group and the control group. These are the probabilities. And quality and cost data. Very simple, that if you are in I with ventilation, you're 50% alive, 0.5, and extubated means 1, and death means 0. And daily cost, if you are intubated to 2,000, you are extubated 1,000, and when you are dead, no cost. And then your iteration start. There are 28 iterations done. This is no intervention case actually. You have to do the same thing for intervention case. What we find here? Day 0, these are the days actually. So cycle here is day. First day, intubated, all of them are 1,000. So it is basically the reverse thing. That is, you are in a bad position initially. All 100 people intubated. Nobody in E group, nobody in D group, nobody. This is the percentage actually. I'll come to that. But I, E, D, these three are important. In the first day actually, that means the second day, I reduced. So good thing is happening here actually. I reduced and E increases. So 10 people came out of ventilation, but 2 people died, 2.2 people actually. And by the same way, it goes like this. In 28th day, 7.19 is I, E is 57.21, death is 35.6. So death will increase anyway. And if you look at the percentage of extubated who are alive, that is 57.21 divided by 57.21 plus 7.19, it will be about 89%. So it gives you a good picture that what percentage of people are getting out. You calculate QALYs, cumulate QALYs, you calculate daily cost, you calculate cumulative cost. And then to give, show your boss the primary outcome. This is not cost effectiveness ratio, but it gives a good picture actually, that blue is intervention and red is control. Horizontal axis is days, and vertical axis that how many what percentage of people successfully extubated. So the value we have got here, it initially 0.1, 0.19, 0.28, like, and ultimately 0.89. So this is the red one is showing that progression, but blue one is showing the with intervention progression. So it clearly shows that as a result of intervention, our extubation is faster. No, we are taking out ventilation more quickly. And what is the cost effectiveness analysis result? This is directly value I am putting here. Cumulative cost, this intervention, this it was found there. Incremental cost is second minus first. Cumulative quality, this for intervention, this again the incremental quality, and finally $177.3 to generate a quality through the intervention. Now, if you apply the benchmark, as you know, threshold, this is much below the usual thresholds. Thresholds are actually in thousands. Or if you take WHO threshold, that your cost per quality is less than the per capita GDP, then even in that sense also per capita GDP is much more than 177. So it is very cost effective to do this intervention. That's what they have found. And so that is the study. So, any question on this or anything? Is it okay, or should I repeat? I mean, is there any problem that, or maybe the whole thing is problem, you couldn't understand anything or part of it? You just feel free to say that. And go back.
So we understood the thing is they are very difficult, but we have to recapitulate again and again. Otherwise, it will not enter our brain. But we understood whatever you have taught. So,
I mean, conceptually, it's not so difficult. And,
Yes, yes.
the difficulty may be in basically that how do you conceptually, it's very simple. That there are different states there, and patients are moving from one state to another state without intervention and with intervention. So basically, first you calculate that with intervention, what is the total cost of if these many people are staying in ICU? And with intervention, what is the cost of these many people are staying in the ICU? And difference of them is the incremental cost actually. So that kind of thing actually, I mean the whole, there in decision tree model actually, we looked at different options, but here we are looking at different states. That's the difference.
And we are computing the cumulative part. This cumulative part is different from the decision tree. In the decision tree, we are not taking the cumulative things because we are not doing the.
No, decision we are not taking the cumulative because decision is basically a snapshot. It is once. And where here it is goes on year after year after year or day after day after day. So you have to consider all costs. Day one cost, day two cost, day three costs. So, and not only that, you have to discount that also. So that's the difference. Otherwise, it's more or less the same.
Yes.
The major limitation is that, which is now new models actually, Markov models, that there's no account taken of history. You are not really considering the difference of two patients based on their history. One might be the basically relapsed case, and another maybe the new case. So, but there should be difference there, but that difference is not there. So it doesn't make any difference between one patient to another patient. So uniform population and all of them are equal and constant risk. Now that has been now changed by what we call a relative risk ratio using RR value. I mean, those who are in public health, they know the relative risk ratio, that parameter you can use, and then probably can address that. Or these limitations are usually offered when instead of 2 or 3 states, you take a large number of states, so that the difference between 2 states are not very much. It's not from hospital to direct death kind of thing. So there are many steps you can, many states you can imagine that hospital staying for just 2 days. This is one state. Hospital staying for 7 days, another state. So according to the severity and according to the progression of the disease, you can have more states. And the more states you do, the more you can handle this problem. If not possible, then there are other methods, individual sampling models, descriptive and similar. We talked about that, but we are not going to discuss those things here. So the basic thing is that there are many people nowadays using Markov model. The paper I have given in your package, you will see that there are few papers actually which are India-based. For example, this was done by Chandigarh PGIMR. This okay, so I need to, sorry. Can you see this?
Yes, sir.
So
Yes,
this
sir.
is, for example, cervical cancer prevention in India. So all of them are Department of Community Medicine and School of Public Health, Chandigarh. There are some other institutions involved there. And what they did actually, they followed the Markov model. You see, they had different stages they have taken. And accordingly, this is the Markov model. They say figure 1 Markov model. So this is the way they did. And it's interesting actually, the model parameters, all the parameters, and where from they get these values, probability values, mostly probability values, and base value is given. And the distribution, beta distribution, which means that when you simulate, so from one data, you generate thousands and thousands of computer generated data. You need to tell your computer or software that what distribution is this. Then accordingly it will generate. So there are sensitivity analysis also, they have done that. So this is one example. There is another example is there. I don't know whether you can see this. Can you see this thing in another article?
Okay. No, sir.
No, sir. Still not.
No. Okay, so it is basically I have to stop share and again do that. So this is the one. So this is for hepatitis C in universal coverage scheme of India. So they have done a lot of studies on different drug combination and different disease actually. I also given some HIV/AIDS case. There are lots and lots of market modeling been done because HIV is very interesting for the public health people, researchers, due to the states and the transition between one state to another state. It is a long-term disease, and then but it progresses, so it allows you to see the steps So that's why it's so much there. For some acute disease, it's very difficult to do this kind of thing. You don't see so many states, right? People just die suddenly. So, for example, road accident, and these are the very acute cases where either you leave well or you die. That is the issue here. So these are the types of, and I have included some other papers from other areas where they have seen that. So whenever you time, just look at this thing, whether you can understand what they have done. And then when you understand that, then you try yourself that whether I can do this. And especially if you can access the Excel, or if you access the, what we call this, Triage software. Triage can also does the thing, and it generates all the curves, all the probabilities, etc. And it also gives you Monte Carlo simulation, so you simulated numbers, etc. So it needs some practice, of course, not just 1 hour going through this process. Definitely is not enough, but it should be now enough. If you continue with that, it should be now enough to understand most of the papers, very basics of the papers, that what is going on now. So if you look at the BMJ Global Health or BMC Health Services Research, Health Policy and Planning, or this kind of journals, these are open access journals, so you can just get free articles there. Health Policy and Planning is not a free journal, but some of the articles you can access, they give open access. So just in your leisure time, you go to the websites and see that what is the latest articles they are publishing. And I think that most of you do these things, so I don't have to tell you. But PLOS1 is another one where this kind of articles very regularly published. And once you see that, you just read that, you see that what they have done, and then gradually you will probably feel interested to do it yourself. So that's from my side. Now I will have open session. In the open session, practically what I want to know that if you have any idea of doing any studies, then we can discuss that how these things we can use and can be helpful, and what should be the research question, and how can we frame the research question and then design the research. So if any idea, if you've already done that, it will be very good if you share that with us so that we learn from you that what you've done, or from your student or from your friend or whatever you've done. Amrita Samanto. So what is the idea?
So actually, this is this type of course. This is my first time I am doing this health economics. So I have only idea about these basic things. So I never had these things before. So I will.
But some of these tools are not only used in health economics, they are used in epidemiology also. For example, you will see some studies where the forecasting of COVID-19 cases are being by using Markov models. They are forecasting that how many patients will be there at ICU, how many there will be inpatient there. So those kind of things, even without considering cost or anything, just the forecasting. So maybe you can also look at from that angle also if you want to do that. Decision tree, for example, is also used for many epidemiological studies where you don't do the cost effectiveness or anything. Just look at the effect part.
Yes, yes. I have seen, but I have never done it. Sir, I will do. I am planning to do it.
Why do you what?
This planning to do this kind of analysis, this kind of studies. But
Okay.
it was okay. But
Some of the people in West Bengal, they're sitting on gold mines after this COVID-19, especially those who are working in the departments in COVID-19 and etc. I don't see Dr. Sanjeev today, but so maybe this is the time to use this data and see that whether something can be done here. Rigu, what is your idea?
Sir, actually, I was going to the course keenly, and in the advanced part, many of the things are new to me. So, like as you said, that these Markov models are often used in epidemiology also in forecasting.
Yes.
Yes, but till now we know this as a theory, but we are still to apply it practically. So that, as Dr. Amrita already said, that it's high time we try our hands on that.
Probably that one thing that can be that I don't know any institution does have that software or not, works with that. But you purchase them, and then some other people can use that software. Probably they are so that, or maybe just free Excel add-in. I have given link so you can download it and start with Excel, and that will be enough. Right, Dr. Shantanu Ghosh, anything to share? Anything you can say? What will you do with this type of knowledge? Any idea? Anything that you want to do?
Yes, definitely. I will try to conduct at least some basic cost effectiveness analysis study. But
yes,
indeed, I don't have any particular research question in my mind.
Okay.
And if possible, I would like to incorporate this knowledge into writing at least a small handbook for the postgraduate students.
Oh, that would be great, actually. I mean, one thing all of you can do now, and which I'm saying again and again, that you can download some papers I have given, but you can Google and you can download some papers and read those papers. Otherwise, what happens that after 5 days, all this training program will be useless, because after you will start forgetting everything, and then after 1 year, somebody asks, yes, I had a course of that, but I forgot everything. That kind of thing happened. So you spent, all of you are busy professionals, so you are really using your time here. So I wish that could be useful in some way or other. At least, if you can understand one paper, then that would be good. That will also be a good output in this thing. So anybody, any suggestion, anything that to ask? Dr. Shanti, I have not heard you.
Sir, thank you, sir.
Thank you, sir. Thank you. Thanks will not help.
Course.
What will help is basically now, some way or other, you use make some time and then do some things. And do a small study. Why don't you form a group and do some quick studies kind of thing? You don't have to publish initially, but at least if you get some results, then you get. Some of you are working in hospital and you have a lot of data, so you can or maybe some easy way to through your students collecting data. So that can be used. Or they
Sir,
can-
from where can we access the all the cost related data?